Thank you, Mr. Chairman, my audience. أشكر طبعا جامعة أسوان والشركة المنظمة. My presentation today about highly purified human menopausal gonadotropin. All of us know that highly purified human menopausal gonadotropin contains menopausal FSH plus FSH. FSH is the main factor which induces folliculogenesis, but we should ask ourselves whether we are actually in need for LH or not. The general consensus is that some LH activity, even if minimal, is necessary for final oocyte development, and cycles devoid of LH are considered unnatural. Yes, this is a scientific assumption, but whether this scientific assumption is clinically relevant or not, we should confess that the human follicular physiology is much more forgiving than many clinicians would believe. For example, the woman may receive suboptimal dose of gonadotropin, but you may find that the response is well and good. So this is what's meant by much more forgiving. Yes, we agree, this is true, but to a certain level or to a certain degree. And we should agree that the LH induces what's called term oocyte maturation, or what's called TOM. The oocyte, it looks like a newborn. It looks like a preterm newborn. So oocytes which are exposed to suboptimal level of LH may be developmentally or apparently mature, but functionally is still not yet mature, even not capable for fertilization, or will yield a suboptimal embryo quality. In the market, what about the sources of LH activity? Either urinary LH, pituitary HCG, as an alternative to LH, or placental HCG, which are the recombinant LH. The best one is the urinary LH, but unfortunately, this is not available because the process of gonadotropin purification inevitably will lead to loss of this LH. So it's not available, the urinary LH. In the market commercially, we have two types of LH activity, either the pituitary HCG or placental HCG. These are the two types which are available in the Egyptian market. Which is better? Which is the best? The pituitary HCG is physiologic. It is released throughout by the pituitary gland throughout the menstrual cycle. It has a relatively short half-life of about 6 to 12 hours. In contrast to the placental HCG, which has a very long half-life, its effect will last for about 5 days or even more. You should always keep this information within your mind, because at the end of the presentation, you should decide which one is the best. The journey of this highly purified gonadotropin started for about more than 20 years with the introduction of the pituitary HCG, and more than 10 years with the introduction of the placental HCG. The first study, which in about 22, what's called the ESSEG study, which proved the efficacy of this highly purified human menopausal gonadotropin compared to the recombinant FSH. This study reported a comparable pregnancy rate between the highly purified HMG and the recombinant FSH. And the alleged problem of patch-to-patch consistency was not found in many studies. Then come about 4 years later, one of the largest studies, which is the MERIT study, which is the first randomized controlled study which was used to evaluate the efficacy of this highly purified HMG compared to the recombinant FSH. This study reported as interesting finding is that the highly purified human menopausal gonadotropin was yielded a significantly less number of oocytes, but on the other hand, associated with a more natural hormonal milieu when compared to the recombinant FSH, mainly more androgen, more estradiol, and less progesterone. And this has reflected upon the pregnancy rate. This differential endocrinal environment improves the pregnancy rate due to improvement of the endometrial receptivity. Then many studies proved that, okay, even the highly purified HMG was associated with less rate of aneuploidy or better rate of good quality embryo when compared to the recombinant FSH. And this study yielded a very interesting conclusion, is that the benefit of highly purified HMG is more apparent in older patients. That means that women 38 years or more will get much more benefit when using the highly purified HMG compared to the younger woman. Why? This is no doubt that the younger patient definitely derive benefit from superior treatment, but because of their much more genetic competency, they are more able to compensate for inferior treatment. This means that in older patients who are suffering from more genetic incompetency, there needs a much better superior treatment to improve the embryo quality. And lastly, in about 3 years later, the megaset trial. This is a very large multicentric study which done in both agonist and antagonist protocol, showing that the live birth rate between the highly purified HMG and the recombinant FSH are nearly comparable, both in fresh and in frozen cycle. Many studies show that the amount needed to achieve a live birth rate is much lower when using the recombinant FSH compared to the highly purified HMG. Whether this is true or not, which is more stronger, the recombinant FSH or the highly purified HMG? As a general, the urinary preparations are more acidic. The recombinant FSH is more basic. The basics, that means the recombinant FSH, are more biologically active. So we anticipate a much more number of oocytes retrieved. So less dose and stimulation days are expected. This is another scientific assumption. However, many clinical studies yielded different results. And many studies show that the amount needed by both hormones to achieve a live birth rate both are similar. And this was attributed to the fact that the extra potency or the extra power of the recombinant FSH is blunted by the absence of LH. As we stated in the early part of the presentation, LH is necessary for final oocyte maturation. During your ovarian stimulation, if you want to combine the highly purified HMG with the recombinant FSH, how you should behave? The use of highly purified HMG can be graphed as a linear continuum. This line, okay, represents a left side. On the left side, the woman used purified FSH, recombinant FSH, without any amount of highly purified HMG. On the right side, the woman used exclusively highly purified HMG. And in between, middle, it's a different concentration from combination of recombinant FSH and highly purified HMG. What about with the results of this interesting study? Stimulation on the right side. Stimulation on the right side, which is exclusive highly purified HMG, yielded a 5% higher live birth rate than the left side. Not only that, in the middle of the continuum, the pregnancy rate was higher when higher amount of highly purified HMG is used. Truly speaking, this 5% is statistically insignificant, but this difference is little but large in the human terms, representing about 9,000 live births per year in the USA only. And lastly, what about the take-home message? Up till now, we didn't answer about the main goal of the presentation, which is Peter, that the highly purified HMG that's of placental origin or of pituitary origin. The general consensus, the highly purified HMG is associated with a higher live birth rate when compared to the recombinant FSH, but honestly, the last recommendations by the ISHRA or guidelines, both are equally effective regarding the live birth rate. It was stated that pituitary HCG, it's appeared in the market about 20 years. With the appearance of the placental HCG in 2013, many studies found that, including randomized studies, that the highly purified HMG that's containing LH of placental origin is associated with a higher number of oocytes when compared to that of pituitary HCG. And less stimulation days. وده عمل many conflict between the manufacturing company, which are Fearing and EPSA, okay, to the degree that the Fearing reported medical claim to the European Agency of Pharmacy, and up till now, this claim has not yet been closed, okay, which is the best another way. What's meant by bad and good? Firstly, before answering this question, you should ask yourself, what do you mean by good? What do you mean by the best? What do you mean? The physiologic or the powerful? This will depend upon your attitude. You need an extra number of oocytes, or you want to imitate the nature. The difference is clear. Whether you are main concerning upon the quality or the quantity, okay? Generally speaking, quantity does not always matter, okay? But sure, the quality always does or always matter. We are not in need for a high level of LH. And if you use a large amount of LH or a powerful LH from the start of stimulation, this may lead to premature progesterone elevation, which will affect the endometrial receptivity, and this has been proved in many studies. Concisely or briefly, the highly purified HMG with pituitary HCG derived LH activity is the most physiologic. On the other hand, the other type is the most powerful. You can select as you want depending upon your attitude. But we should reach a compromise. The studies are divergent. We don't have a definitive conclusion that to the degree that the ASRM in 2012 stated that insanity is to do the same experiment, the same thing many times, but expecting different results. But we should all, as a gynecologist, we should always confess that The field of gynecology and the IVF in particular leads the list of being the least evidence-based specialty. We should say that sadly, but with shame. And the Lancet states that there is nothing certain in medicine. You may use a powerful gonadotropin, but you may find a bad response, and vice versa. And it states that medicine is a sign of uncertainty and an art of a probability. So you should, the final solution, you should consider the medicine, and the ART in particular is an art. Yes. And the main goal of this art is to imitate the nature. And lastly, I'm always closing my presentation with this immortal statement: knowledge looks like an endless puzzle. The more picture you will put, the more new question you will gain. And thank you.